Yes, sir.
Who is presenting first? Yuta, Shobika, or Vidya? Who is presenting?
Sir, I'm presenting, sir. Good evening, sir.
Good evening.
Uh, my topic is on mitral stenosis in pregnancy. Mitral stenosis refers to decrease in mitral valve area. The normal mitral valve area is 4 to 6 centimeters square. The most common cause of mitral stenosis is rheumatic heart disease. Rheumatic mitral stenosis forms 88% of heart disease complicating pregnancy in India. Other causes of mitral stenosis is SLE, rheumatoid arthritis, Hunter-Hurler syndrome, carcinoid syndrome, infective endocarditis, amyloidosis. A criteria to diagnose rheumatic fever is called Jones criteria, where we have five major and few minor criteria. The five major criteria include carditis, arthritis, subcutaneous nodules, erythema marginatum, and synonym scoria. Minor criteria includes a fever, there is temperature greater than or equal to 38.5 degrees Celsius, polyarthralgia, prolonged PR interval on ECG, ESR greater than 60 millimeter per hour, CRP greater than 3 milligram per deciliter. Pathophysiology of mitral stenosis. Rheumatic fever leads to cardiac inflammation causing pancreatitis, which heals with scarring and affecting the valves. Repeated episodes of acute rheumatic carditis will lead to chronic mitral valve leaflet inflammation, which will cause the fusion of mitral valve leaflet commissures, resulting in calcified valves. When normal mitral valve area of 4 to 6 centimeters square is progressively reduced to 2 centimeters square, classical symptoms of mitral heart starts to appear. So in a mitral stenosis, there will be decreased emptying of left atrium and subsequent filling and decreased subsequent filling of left ventricle, which leads to decrease in stroke volume and a decrease in cardiac output. When stenosis progresses, there will be an enlargement of left atrium, resulting in high left atrial pressure. So the pressure gradient develops during diastole between the left atrium and left ventricle. Uh, this causes back pressure on pulmonary vessels, resulting in increased in pulmonary vascular resistance, causing pulmonary congestion and in severe cases, pulmonary edema. Long-standing pulmonary venous congestion will result in irreversible vessel changes leading to pulmonary artery hypertension. Coming to grading of mitral stenosis. Grading of mitral stenosis is based on the mitral valve area, the pressure gradient, and pulmonary artery mean pressure. The severity is graded into mild, moderate, and severe. In mild cases, the mitral valve area is 1.5 to 2.5 centimeters square. The pressure gradient is 2 to 6 mmHg, and the pulmonary artery mean pressure is less than 30 mmHg. In case of moderate lesions, the mitral valve area is 1 to 1.5 centimeters square. The gradient pressure is between 16 to 12 mmHg, and the pulmonary artery mean pressure is 30 to 50 mmHg. In case of severe mitral stenosis, the mitral valve area is less than 1 mmHg, the pressure gradient is greater than 12 mmHg, and the pulmonary artery mean pressure is greater than 50 mmHg. Pregnancy aggravates mitral stenosis by the following things. It increases in pregnancy, the blood volume increased to 30 to 50% at first trimester, resulting in increased capillary hydrostatic pressure, which will causes the increased risk of pulmonary edema and congestion. And there will be physiological hypovolemia and increase in heart rate, which will cause decrease in diastolic filling time in the left ventricle. There will be a decrease in systemic vascular resistance, and in pregnancy, there will be increased atrial irritability and increased hypercoagulations due to the changes in hemostasis. This causes the risk of atrial fibrillation and left atrial thrombus. There will also be a cardiac decompensation and pulmonary edema, which will occur in pregnant women with a silent mitral valve stenosis during second or third trimester. And the risk of maternal death is higher during the labor and immediately postpartum period. Coming to the symptoms, the patient might have breathlessness due to the pulmonary congestion and the low cardiac output, hemoptysis, which is again due to pulmonary congestion, could also be due to pulmonary embolism, and then cough, which could be due to pulmonary congestion, and fatigue, which could be due to a low cardiac output state, and patient might have chest pain due to pulmonary hypertension. The patient might have edema and ascites due to right heart failure. The patient might have palpitations because of atrial fibrillation, and thromboembolism because of atrial stasis and atrial fibrillation. Clinical signs. The patient might have mitral phases, that is mild cyanosis of lips and cheeks and malar prominence. Patient might have increased JVP, right parasternal heave, hepatosplenomegaly, ascites, edema, atrial fibrillation, and then the patient will have on auscultation the patient will have loud S1 opening snap, low pitched rough rumbling mid diastolic murmur heard at the left fifth intercostal space with bell of the stethoscope in left lateral decupitative position, breath held in expiration. Coming to investigations, routine CBC blood grouping cross matching is done, coagulation profile, LFT, RFT, serum electrolytes, and then we'll ask for ECG, chest X-ray, and echo. In ECG, there will be bifid P wave in 2-3 AVF because of left atrial enlargement, and then there will be dominant R wave in V1 and V2 because of right ventricular hypertrophy. There might be right axis deviation. In chest X-ray, there might be straightening of left heart border, a slightly enlarged cardiothoracic ratio, small aortic knuckle due to decreased cardiac output, curly B line in case of pulmonary congestion, posterior displacement of esophagus by enlarged left atrium, double shadow in the mid position of cardiac silhouette due to left atrial enlargement. Echo is done to assess the severity of lesion. In echo, we can measure the mitral valve areas, extent of mitral regurgitation, left ventricular systolic function, and pulmonary pressures. And we can also look for left atrial clots. We can also ask for cardiac enzymes, mainly BNP and troponin. BNP is also increased in preeclampsia and heart disease. Troponin is also increased in gestational hypertension and preeclampsia. The cardiac risk prediction is done with NIHA grading, heart failure stage classification, which predicts risk in non-pregnant population. And then we have CARTEX score, that is cardiac disease in pregnancy, and modified WHO risk score, that is this also useful to assess the cardiac risk during pregnancy. Coming to MS and pregnancy, in patient with MS planning for pregnancy, preconceptional education to female and the family regarding the disease and its possible impact on mother and fetus is explained. And then according to the severity of mitral stenosis, functional status of the patient, management and intervention is advised. Patient with a severe mitral stenosis and pulmonary arterial hypertension must be counseled against pregnancy. In case of medical management, will advise beta blockers to control the heart rate, and then diuretics if the patient has any congestive symptoms, digoxin and beta blockers in patient with atrial fibrillation for rate and rhythm control, and anticoagulation in patients with mitral stenosis having atrial fibrillation. The target INR should be 2.5 to 3.5. And then preconceptional intervention is percutaneous balloon valvuloplasty, which is advised if the patient has moderate to severe mitral stenosis with valve area less than 1.5 centimeter square, and it and can also be advised in patients with reduced functional status and symptomatic patients. Coming to in a patient diagnosed with mitral stenosis during pregnancy. In a patient with mitral stenosis who's pregnant, clinical signs and symptoms and functional status assessment is done. Early termination of pregnancy is advised if the patient has severe mitral stenosis with pulmonary artery hypertension, severe LV dysfunction with ejection fraction of less than 40%. If pregnancy is considered to be safe in those patients, then medical management with bed rest, salt restriction, diuretics, and beta blockers is advised. Option for interventional procedures like balloon mitral valvoplasty is advised if mitral valve area is less than 1 centimeter square and the symptomatic patients where medical management fails. Percutaneous balloon mitral valvoplasty is ideally performed between 12 to 14 weeks of gestation to minimize the fetal radiation exposure. If patient can be stabilized with medical management, procedure can be delayed to 26 to 30 weeks gestation to reduce the risk of preterm delivery. In patients with prosthetic valves, management is based on the type of prosthetic valve, cardiac evolution, and anticoagulation therapy. Mechanical prosthetic valve patients requires lifelong anticoagulation. Bioprosthetic valve patients requires anticoagulation for first 3 months following the valve placement. In the patients who are on anticoagulant, in the first trimester, we can avoid warfarin or warfarin with limiting the daily dose less than 5 mg, or it is ideal to use unfractioned heparin in the first trimester. From 12 weeks to 36 weeks, we can consider anticoagulation with heparin with target INR of 2.5 to 3.5. And from 36 weeks, we can consider warfarin stoppage and bridging with low molecular weight heparin. The therapeutic low molecular weight heparin should be stopped 24 hours before surgery. Prophylactic low molecular weight heparin should be stopped 12 hours before surgery. Warfarin should be stopped 5 days before the surgery. Unfractioned heparin should be stopped 4 to 6 hours before the surgery. Coming to obstetric and anesthetic management. Management of mitral stenosis in pregnancy should be multidisciplinary, which include involvement of obstetrician, anesthesiologist, cardiologist with detailed counseling to patient and her family. Assessment of cardiac lesion, severity of lesion, and management should be discussed. Intense hemodynamic monitoring to be done during and after delivery for at least 72 hours post-pregnancy. The mode of delivery, it could be vaginal or cesarean. In case vaginal delivery is preferred in mild to moderate mitral stenosis patient, NIHA grading 1 to 2, and then if there is no associated pulmonary artery hypertension. In heart disease patient, vaginal delivery under epidural analgesia is recommended unless there is any contraindication. Coming to cesarean delivery, which is performed in severe mitral stenosis cases, NIHA grading 3 or 4, and the presence of pulmonary artery hypertension, and if there is any obstetrical indications. Cesarean, choice of anesthesia could be neuraxial or general anesthesia. Goals of anesthetic management: maintenance of low normal heart rate, avoidance of iodocaval compression, maintenance of adequate preload, maintenance of systemic vascular resistance, avoid decrease in systemic vascular resistance, avoid increase in pulmonary vascular resistance, prevention of pain, hypoxemia, hypercarbia, and acidosis, maintain sinus rhythm, be prepared to cardiovert if patient gets atrial fibrillation. Preoperative medications. Antibiotic prophylaxis is recommended in patients who is suspected to have bacteremia and active pelvic infection, and a patient with a prosthetic valve, prior endocarditis, unrepaired or incompletely repaired cyanotic heart disease, first 6 months after complete repair, and valvuloplasty after heart transplant. According to ACOG recommendations, the following antibiotics could be given, that is ampicillin, cefazolin, ceftriaxone, and clindamycin. Antibiotic prophylaxis to be given within 1 hour of surgical incision. And then anti-aspiration prophylaxis, H2 receptor antagonist, proton pump inhibitors can be given, and beta blockers should be continued for the rate control. Intra-op management. Patient should be monitored with ECG, BP monitoring, pulse ox, temperature monitoring, and urinary catheter. In patients with NIHA class 3 and 4, invasive BP monitoring should be considered. And then fetal heart rate should be monitored during induction of anesthesia until the beginning of skin preparation. The patient positioning should be in supine position with 15-degree left lateral tilt has been proposed to significantly reduce the supine hypotension syndrome. And then we need to acquire IV access with a large bore cannula. The choice of anesthesia could be neuraxial or general anesthesia. Neuraxial anesthesia. Neuraxial anesthesia or analgesia for labor and vaginal or cesarean delivery can be safely performed in patients with mild to moderate mitral stenosis. Neuraxial anesthesia for cesarean section is best administered with a titratable technique, either epidural analgesia or sequential combined spinal epidural anesthesia. Adequate analgesia in the first stage of labor is essential. Intrathecal administration of lipid-soluble opioid in the first stage of labor provides excellent analgesia without sympathetic blockade. Neuraxial administration of opioid with a low dose of local anesthetics provides satisfactory analgesia in second stage of labor. Judicious intravenous fluid administration is to be maintained. Titration of phenylephrine is done to maintain the hemodynamic stability. Coming to general anesthesia, the indication is severe mitral stenosis with pulmonary artery hypertension, patient refusal to neuraxial anesthesia, contraindication to neuraxial anesthesia like coagulopathy, sepsis, local infection. So here all pregnant women is considered as full stomach patient. Anti-aspiration prophylaxis should be administered. We need to arrange for blood products preparation. We need to keep the emergency drugs, difficult airway cart, and defibrillator ready, and to attach monitor as per standard ASA monitoring. Again, we have to secure the large bore IV gas cannula. Patient placed in supine position with the left lateral tilt. Uh, Coming to induction, after pre-oxygenation for 3 to 4 minutes, modified rapid sequence using succinyl choline or acronym is done using etomidate, which is titrated to effect. Propofol is not indicated. It might cause a precipitous hypotension, so it's better to avoid propofol. And then the laryngoscopy should be gentle to avoid the laryngoscopy response, and perform tracheal intubation with a small size CT tube, 6 to 7 mm. And then we need to maintain anesthesia with oxygen and sevoflurane. Nitrous oxide is to be avoided as it raises the pulmonary vascular resistance. And we need to avoid muscle relaxant with the histamine release. And we need to maintain normothermia. Use short-acting beta blockers like esmolol for the rate control. Intraop fluid should be carefully titrated to avoid fluid overload. Avoid intraop hypoxia, hypercarbia, acidosis, as it can increase the pulmonary vascular resistance. Once the delivery is done, oxytocin is given, 2 international units IV bolus, not less than 15 seconds, followed by 2 international units for the next 2 hours. We need to monitor blood loss and respond as necessary. Extubations should be smooth, need to avoid wide fluctuation in hemodynamics. Post-op management. Continuous vital monitoring for the next 72 hours is necessary. We need to avoid hypothermia and shivering. Judicious fluid administration is maintained. Multimodal balanced analgesia technique to prevent undue sympathetic stimulation using systemic opioids, paracetamol, NSAIDs, tab block, ESP block, and epidural analgesia. And we need to monitor the urine output, thromboprophylaxis measure, and early mobilization, and resumption of anticoagulations. Where warfarin can be started 24 hours post-operatively, and therapeutic low molecular weight heparin can be started at 12 hours post-operatively. That's all, sir.
Okay. That's a fairly decent presentation for a theory question answer. Okay.
Yes, sir.
But your answer is a little bit jumbled up. You are talking about cesarean section, and then immediately in between in the pre-induction phase, you are going to first stage and second stage of labor as though you are conducting a normal delivery, and then going to induction, and then talking about drugs and all that. So it has to be sorted out. If you are talking about performing a normal vaginal delivery, you must talk about the stages of labor, how you will conduct, how you will prepare the patient, how will you have a consultation and talk with the gynecologist and perform a labor analgesia as early as possible and monitor the patient throughout the various stages of labor. Okay.
Yes, sir.
And if it is an indication for cesarean section, then you must plan how you are going to do the cesarean section. It may be elective, or it may be an emergency, or it may be a failed natural delivery attempted which failed, and then it has converted into a cesarean section. These are the 3 indications. The planned elective cesarean is not a problem. You can start the patient adequately. You can have all the facilities, and it will be done at a time very convenient for both the surgeon as well as the anesthesiologist. But if it is a emergency surgery due to fetal distress, or the patient arriving late with some intervention done outside and then coming for emergency delivery, then it is altogether a different question with they always the chance of full stomach and aspiration and there both during regional as well as general anesthesia. And you must plan your anesthetic technique in such a way that you will be able to avoid that. And you won't, at that situation, you won't know about the pulmonary pressures and the condition of the patient, because you have very little time to assess the severity. So by simply asking the history of what is the effort tolerance, what is the frequency of admission with congestive failure symptoms in the hospital, you have to make a rough assessment of the patient's previous severity of the mitral stenosis. And one important point you have to clarify, I mean, very insistently say in your answer is, after the delivery of the baby and the delivery of the placenta, the uterus goes into contraction. You talked about giving uterotonics like cytosinon and other things, how to contract the uterus. But at the time, what will be the auto transfusion that will be taking place? It will be almost like 500 to 1000 ml of blood will be auto transfused into the patient, and that will form a sudden violent preload to the heart, which will precipitate a pulmonary edema. Okay, that is a very, very important step in management of any patient, whether they go through normal vaginal delivery or whether they undergo cesarean section. The third stage after the immediate removal of placenta is a very important stage where auto transfusion of the blood will happen because of the uterine contraction, and you have to judiciously adjust your fluid, and if necessary give a small dose of Lasix well in advance so that this fluid overload will be tackled and they will be able to excrete it as urine before it poses a very great strain on the heart by a massive preload coming to the heart. Okay, so that is a very important point that has to be mentioned. But otherwise, you have mentioned all the other things with mitral stenosis in relation to pregnancy and its management. This answer is very well prepared. Only thing you have to sort out it and mention it as I mentioned for management during normal vaginal delivery, management during elective cesarean section, management during quasi-emergency and emergency cesarean section. If you prepare and sort out the answer, you have all the points in your answer. But if you classify in that way and present it, it will look more appealing and it will look as though you have well understood the problem also. And as far as mitral stenosis is concerned, mitral stenosis complicating pregnancy is one of the common things that will be kept in the exam. In Viva also, they can keep a patient if they have a patient with mitral stenosis. Or in your other surgical non-pregnant patients coming with mitral stenosis for an incidental surgery like a hernia repair or a, some laparoscopy or a gallbladder repair, I mean excision. These things are also quite common. So mitral stenosis, you should know something about, especially from Viva point of view, you should know something about the etiology. What is the most common etiology?
Rheumatic heart disease.
Rheumatic heart disease. So they may ask all questions on rheumatic heart disease. How does rheumatic heart disease cause this problem? You said repeated carditis will produce scarring. What is the molecular mechanism behind that?
Sir, rheumatic heart disease due to streptococcal infections.
Okay.
What
type class of streptococcus? All streptococcus, or is there a classification?
Streptococcus B, sir.
Hemolytic beta, hemolytic streptococci. Okay.
Yes, sir.
So what is that? What do they do? How do they produce this inflammation?
Sir, repeated attack of the streptococci B will cause autoantibody stimulation, so that molecular mimicking, it will mimic
Molecular mimicry will happen. Yeah.
Yes, sir.
So why does molecular mimicry attack these heart valves? And why mitral valve is the most preferred valve which is affected compared to, you have aortic valve, you have pulmonary valve, you have tricuspid valve, but why rheumatic heart disease affects mainly the mitral valve and next only the other valves? Which tissues they affect? This the antibody production, which is against the antigens produced by the beta hemolytic streptococci, because which particular constituent in the body mix the antigen so that the antibody mistakes it as the antigen of the hemolytic streptococci and starts fighting with that and produces inflammation and fibrosis and scarring and all these things happen. It is against the fibrous tissue, okay? Because the amino acid sequence in some of the fibrous tissues are similar to the antigen which is produced by the beta hemolytic streptococci. So body thinks that these fibrous tissues also as an antigen and they start attacking it and produce the inflammatory reaction which ultimately heals by scarring, and mitral valve gets affected maximum because that is the largest valve in the body, the heart. As you said, it is 4 to 6 centimeters square and it has got more fibrous tissue compared to the other valves. Other valves are all smaller than the mitral valve. So that is the reason why. And secondly, the force with which the blood flows through that, the shear force is also more there compared to the other valves because left side pressures are much lower, whereas right side pressures are much lower compared to the left side pressures. So these are the two reasons why the mitral valve is affected most in the infection with this beta hemolytic streptococci. And once a person is affected, so we more or less this is considered as a autoimmune disease because the antibodies affect the body's own tissues instead of the in addition to the antigens produced by the beta hemolytic streptococci. Our own body tissues are also affected, so it is considered as a autoimmune disease. And when will the features of mitral stenosis start exhibiting? Will it happen immediately after the rheumatic fever attacks, or will it take some interval and then it will affect, start manifesting a little later in life?
Yes, sir. It manifests later in life, sir.
Which
Repeated
decade commonly?
second decade, sir. Second to third
Second
decade.
to third decade only it will manifest. Okay, even though the attack may happen during the first and second decade, that before the adolescent or adult age, it will attack the sore throat and the hemolytic streptococcal infection, producing episodes of rheumatic fever will happen between 10 to 20 years. But the manifestations of valve involvement will be exhibited only between the second and third decade of life. And as you said, the grading will be mild, moderate, severe, and critical. That is how based on the valve area, they call it as mild. When it is reduced to almost 50% from 4 to 6, it becomes 2 per centimeter. Then comes to 1.2, then less than 1, then 0.6. Then so it is graded into mild, moderate, severe, and critical mitral stenosis. And the pathophysiology in mitral stenosis, as you rightly said, there is a diminished left ventricular filling because of the narrowing of the valve. So initially, the left ventricular filling is achieved by increasing the left atrial pressure. Okay, normal left atrial pressure is 0 to 5 and it is increased and gradually it increases. Once the increase in pressure is not able to attain the adequate filling of the left ventricle, then the muscle of the left atrium starts hypertrophying or increasing in size. That is the time when left atrial enlargement will start happening. And one important problem of this left atrial enlargement is what is the complication it can produce?
Left atrial enlargement can compress the left recurrent laryngeal nerve, sir. Hoarseness of voice might occur. It
It's
also
a very rare
displaces
thing. That
ease.
is external. But what is the heart complication that it produces?
Pulmonary edema,
Of
sir.
the left atrial, it will cause back pressure of
Pulmonary edema.
pulmonary.
Initial. Once the muscle goes on stretching, is it a thick muscle like left ventricle or is it a smaller thickness muscle?
It will displace esophagus, sir.
Esophagus. Okay. Most initial. See, when the muscle goes on stretching,
Sir,
before it
atrial
becomes
fibrillation, sir.
atrial fibrillation. Yeah, the muscle is not that powerful like left ventricle. Okay. So it starts fibrillating. It is not able to contract cohesively, and once the patient starts developing atrial fibrillation, that indicates that there is already an atrial stretching, atrial enlargement is there. And the filling later on depends on what, which is the most important step in the left ventricular filling. If the passive filling, because of the pressure difference, opening the valve and then trying to fill the left ventricle, the early filling, if it is not happening, the stages of the cardiac cycle. What are the 4 stages in the left side filling the cardiac cycle?
Sir,
Atrial
isovolumetric contraction.
Atrial contraction, is it the first one?
Last
No,
step, sir.
last step.
The first one is the pressure difference.
Isovolumetric relaxation.
Isovolumetric relaxation,
Passive
early
filling.
rapid filling,
Contraction,
period of
rapid
slow filling.
diastasis, and the
Yes.
atrial contraction. Okay, that is how these are the 4 stages of the cardiac cycle. Okay, so the first stage is the left ventricle has to relax, isovolumetric relaxation. This causes a reduction in the pressure in the inside the cavity of the left ventricle. So comparatively, the left atrial pressure is more. This automatically opens a normal pliable valve and blood starts flowing without any contraction of the left atrium itself. This is called the early filling. Once the filling occurs, the pressure between the left ventricle and left atrium becomes equal. That is called period of diastasis, when there is no flow. Then the final filling happens when the atrium contracts and pushes some more blood into the left ventricle. Okay? These are the 4 steps. But here these are the things which are affected. The left ventricle is relaxing normally, but despite the decrease in pressure, because the valve is narrowed, it is not able to open the valve, and even though the pressure in the left atrium is higher, the early rapid filling is not happening in the normal way. Okay? So the equalization, the period of diastasis takes a little longer time to achieve, and finally it is the left atrial contraction or the kick which is responsible for filling, which is normally about 20% in a normal heart. It helps to fill up at least 30 to 40% in the diseased mitral valve state patients. Okay, so that becomes a very important entity. And if they start developing left atrial fibrillation, then the muscles don't contract that effectively. That will affect the atrial kick or the atrial contraction, and that is the time when patients will go in for back pressure and pulmonary edema and all these things. The other complication of atrial fibrillation is
thrombus formation, sir.
thrombus formation. And where will the thrombus form?
Left atrial, sir. Left atrial
Left
thrombus.
atrium, is it a single cavity or there is an adjoining space in that? Is it a single uniform cavity or there is a projection or some other side room in that cavity?
Auricle, sir.
Auricle. It is called left atrial appendage. Have you not heard of the term? There is a left atrial appendage. There is a small projection on the left atrium. Okay, and that is where the thrombus will initially form. So even if you do an echo, you must look for the thrombus first in the left atrial appendage. From there only it will progress and come and occupy the cavity of the left atrium. Okay? So this is a very important step. And once the thrombus formation is there and atrial fibrillation is there, there are a lot of questions that will be asked in the examination about atrial fibrillation, what are the causes, how it is managed, what are the goals in the management, how do you. So if they ask you about atrial fibrillation, what is the definition of atrial fibrillation first of all?
Sir, heart rate greater than 100 minutes per minute. 100 beats per minute.
These are features of atrial fibrillation. What is the definition of atrial fibrillation? When you say a muscle is fibrillating, where else a muscle can fibrillate?
Irregular rhythm, sir.
Irregular rhythm, that is also another feature of irregular pulse is a feature of atrial fibrillation. But I am asking about the definition. What do you mean by atrial? What is the definition of atrial fibrillation? Where else you will see fibrillation? In which disease you can see fibrillation in some other organ, not in the heart? Neurological tongue. Which condition? Neurological condition will produce fibrillation in the tongue. Have you heard of motor neuron disease? Where
Yes,
you
sir.
ask the patient to put out your tongue and the tongue will be fibrillating. So a fibrillation is a discordant or discoherent movement of a muscle without an effective contraction. That is the definition of fibrillation. So atrial muscle which is contracting discordantly or discoherently without an effective contraction is called atrial fibrillation. And the features of or presentations, how you clinically identify is by an irregular pulse. So what is the clinical method of diagnosing atrial fibrillation? Just by irregular pulse, can you say it is atrial fibrillation? Sometimes the ventricular fibrillation or ventricular ectopics also will produce irregular pulse. So how to differentiate or clinically diagnose the atrial fibrillation?
Absent P wave.
Absence of P waves, sir.
P wave in pulse.
Yes, sir.
Clinical examination, where will you get a
Pulse
P wave?
deficit, sir.
Huh?
Pulse deficit.
Pulse deficit. That is the correct answer. Okay, you have to. So how do you examine for pulse deficit?
Sir, we have to auscultate and keep one hand on the radial pulse at the same time.
So you can count both the things simultaneously yourself, or you require help of somebody else.
Two persons and one person should
If you want to
auscultate.
clinically do that, you have to have a helping hand. Okay, one person should auscultate the heart and count the heartbeat. Another person should hold the pulse and count the pulse rate. Both of them should start at the same time and count for 1 minute. And which one will be higher? Which one will be lower?
Heart rate will be higher and the pulse rate.
Heartbeat will be higher and pulse rate will be lower. That is why it is called pulse deficit. All the contractions are not transmitted as a pulse. That is why it is called pulse deficit. Supposing you are all alone, can you clinically make out, if you have a gadget with you, can you make out the pulse deficit without the help of another person?
ECG or pulse oximeter.
ECG is more than the pulse oximeter is very easy. So you can put on a pulse oximeter and start counting at a particular time. Pulse oximeter will tell you the pulse rate. You can count the heart rate and you can find out the pulse deficit. Okay. So that is a very important basic question that the examiners are fond of asking. So how to identify the presence of atrial fibrillation? What are the other causes of atrial fibrillation? Is mitral stenosis only cause for atrial fibrillation? Elderly patients can have
alcoholic.
Okay, then
Underlying
patient with
cardiac
chronic
disease.
lung disease get atrial fibrillation.
COPD.
COPD patients can get. Can thyrotoxicosis patient get a atrial fibrillation?
Yes, sir. Yes, sir.
So you can classify them into cardiac and non-cardiac conditions producing atrial fibrillation. Okay. So once you diagnose atrial fibrillation, how will you? What are the types of atrial fibrillation?
AF with control ventricular rate and AF with fast ventricular rate.
AF with the control ventricular rate and AF with the fast. Is that the way to classify? Is that the way it is given in books?
So
Which book did you read?
persistent and chronic.
Huh?
Acute atrial fibrillation,
Acute.
persistent atrial fibrillation, and chronic atrial fibrillation.
Chronic atrial fibrillation. Okay.
Irregularly
I don't know
irregular
from where you got that, but From the books I read, there are three varieties described. One is paroxysmal atrial fibrillation. Then there is a persistent atrial fibrillation. The third is permanent atrial fibrillation. Okay, all starting with P only: paroxysmal, persistent, and permanent. What is the difference between these three? Why you need to know this classification?
Paroxysmal is
the-
episode.
What is the
Paroxysmal
nature
term
of
is within 7 days.
paroxysmal?
The terminates within 7 days. In case of
7
persistent,
days. It
more
takes
than
7 days paroxysmal.
Within
Less than
48 to 72 hours.
Yeah, paroxysmal comes on suddenly and disappears suddenly. That is why it's called paroxysmal. It may disappear within 12 hours, 24 hours, 48 hours. Okay. So it requires no treatment. Paroxysmal appears suddenly and disappears suddenly, requires no treatment. You can ignore that. Whereas permanent appears suddenly but persists for a longer time. When it's appears staying for more than 48 hours, it is called permanent. And sometimes, if there is a hemodynamic instability, it may require intervention. Otherwise, it may also be ignored. Whereas chronic atrial fibrillation, which you said is called the permanent atrial fibrillation, it requires definite intervention because it can cause two complications. One, it can produce a thrombus formation. Second, it can produce hemodynamic instability if the left ventricular function is already compromised. So, if you decide to intervene, what are the criteria or guidelines for treatment of atrial fibrillation?
Rate
We use
rhythm.
pharmacological for the rate control, sir. Pharmacological
Okay.
therapy for rate
Any
control.
arrhythmia, what should be the first and foremost criteria?
Hemodynamic instability, sir.
You must always look at the hemodynamic stability. If the hemodynamics is unstable, then you have to go for electrical conversion of any arrhythmia. If hemodynamically patient is stable, then you can think of pharmacological intervention. That is the answer expected out of you in the examination, as well as that is also the way to practically go through management of any arrhythmia. So always look at the hemodynamic stability of the patient. If the patient is hemodynamically stable, you can think of pharmacological treatment. And what are the other things that, what are the three things that you have to correct in atrial fibrillation?
Rate control,
to correct the
dose
rate.
Rhythm control.
Rate
and
control, rhythm
anticoagulation
control, and anticoagulation. Okay, these are the three things you have to remember: rate control, rhythm control, and anticoagulation. So the rate should be brought down to normal. And how you achieve that?
With the help of beta blockers, sir.
Beta blocker. Which beta blocker? You have so many beta blockers.
Yes, sir.
Oral beta
Selective
blocker
beta.
or parenteral beta blocker.
We can use parenteral, sir, for immediate thing. Relief.
Which is the
Metoprolol.
parenteral, which is the most commonly used parenteral beta blocker for rate control?
Sir, metoprolol is commonly used, sir.
Metoprolol are much more shorter and easily
Esmolol.
titrated.
Esmolol, sir.
Esmolol can be used. Okay, what is the dose of esmolol?
Sir, 500 mics per kg, sir.
0.5 or 500
0.5
mg per
mg.
kg,
Yes,
IV slowly,
IV.
followed by, can give a bolus dose first, and then you have, if the rate is not coming down, you have to continue it as a slow infusion. Okay, because it's a very short acting drug, isn't it?
Yes, sir.
So any short acting drug, after a bolus dose, you must continue as a infusion. Whereas your metoprolol, it is a longer acting drug. You can give and wait for some time for it to take action. And that is the first and foremost line of treatment. How do you get the rhythm control? What
Sir,
rhythm you
Digox
want to
we can
achieve?
use. We can use sinus rhythm, sir. Digoxin we can use.
Digoxin you can use. What is digoxin?
Sir, digoxin it corrects the myocardial contractility, sir.
What is digoxin? I am not asking what is it doing. I am asking what is digoxin. Please listen to the question. Be patient and then
Cardiac
answer.
glycoside.
It's a cardiac glycoside. Okay?
Glycoside.
And it is a naturally occurring product taken from the leaves of the plant. So it is a cardiac glycoside. How does it act?
Inhibits sodium calcium exchanger.
It is acting on the sodium potassium exchange pump in the heart. Okay, it tries to stabilize the heart contraction, improve the heart contraction, bring down the rate, and try to bring it back to. But is it commonly used nowadays?
No, sir.
No. So what is the other alternative for restoring the sinus rhythm in the patient? It is not
Amiodarone.
pharmacologically.
Amiodarone,
Amiodarone.
sir.
Amiodarone can be given. Very good. If both of them are not helping,
Electrically cardiovert.
you have to do cardioversion.
Cardioversion.
Will you call it as defibrillation or cardioversion?
No, sir, it's synchronized
Cardioversion.
cardioversion.
What is the difference between cardioversion and defibrillation?
Defibrillation can be done at any point in the cardiac cycle, but cardioversion, you have to synchronize it at the point of the R wave.
Okay, that is
So,
one.
and
Anything else?
cardioversion uses much lower energy than defibrillation.
Very good. So cardioversion, maximum you use only about 120 joules. Whereas defibrillation, especially of the ventricular circulature, requires 200 to 300 joules. Okay, so these two differences are commonly asked in the examination, so you must be aware of that. So all these questions are, and coming to the third correction in atrial fibrillation is anticoagulation. So which is the anticoagulant of choice for a patient who has been diagnosed with a left atrial thrombus with atrial fibrillation?
Clopidogrel, sir.
Clopidogrel.
Dabigatran.
Dabigatran. So coming out with all newer agents.
Warfarin, sir.
Warfarin. Warfarin is the mainstay till today. Okay. So warfarin, what type of anticoagulant it is?
Acinocumarol derivative.
Acinocumarol chemically and acts against what?
Vitamin
How
K
does it-
antagonist.
Vitamin K antagonist. So prevents the, what is the mode of action? When it is say vitamin K antagonist, what does it do to the vitamin K?
It inhibits the
Decreases
vitamin K
the
dependent
production of vitamin K.
factors.
You must
It-
tell me the exact biochemical change that is caused in the vitamin K.
It inhibits the enzyme which helps in the production of vitamin K.
Vitamin
So,
K epoxide synthetase enzyme is inhibited.
oxidase enzyme is. Okay, tell me in the next class what exactly the correct answer for this. Okay, right. So, what is the how long will it take for vitamin K? I mean, the warfarin to take effect. Will it be immediate?
No, sir, 5 to
No,
7
sir.
days.
7 days.
5 to 7 days to take action. Maximum 3 days. Okay, once you start giving the drug, it will take at least 72 hours for it to act. So, how can you wait till then? So, is it
No, sir.
advisable to go ahead and give warfarin alone for the anticoagulation?
We have to
No,
start
sir.
with, we have to bridge with heparin, sir.
You have to start anticoagulation with a controllable or a titratable drug like heparin, which has a very short half-life of 4 to 6 hours. So you can give the drug IV or subcutaneous and try to achieve the desired INR to prevent that. Meanwhile, you can start the patient on warfarin, and once warfarin effect also comes on, you can withdraw the heparin. That is the way you anticoagulate these patients. Okay. The dabigatran and Clopidogrel, of course, is not used in these cases. They are purely antiplatelet agents, whereas the newer oral anticoagulants are being prescribed nowadays by cardiologists for anticoagulation in atrial fibrillation patients who are on chronic atrial fibrillation or permanent atrial fibrillation patients for a prevention of thrombus, but not for acute treatment. Okay, it's a maintenance therapy. They are using these drugs. So these are all the points that is expected out of you. So you have to be prepared for answering these questions also. So with this small introduction, I'll just show you the presentation on mitral stenosis and anesthesia as a